We are not gathered here for an academic debate. I hope that we do realize that the healthcare system is at crossroads because people are dying when they should be saved, because hospitals are closing their doors when they should be healing. The recent transformation from NHIF to SHA had promised transformation of healthcare delivery, a system that will finally ensure healthcare access for all Kenyans. But the reality is that we're getting very many obstacles for many Kenyans access to the same healthcare. The workforce strikes, I limit myself to KMPDU, has been a revolving door of crisis. One strike ends, which leads to a document, and that document opens an avenue for the next strike, and so on and so forth. In total, we've had close to 183 strikes in different regions since devolution. Is this a path that you want to go to carry along with? County staffing, misallocated funds. We do have registrars working at the Kenyatta National Hospital and all other referral hospitals, basically keeping forte of these hospitals while being paid nothing. While I may not call it slavery, I lack a better term. We also do have consultants in the various counties working and performing their duties as consultants despite the stringent and constricted resources, while they're employed as junior medical officers because of a lack of standardized policies. In our audience today, we have the former Minister for Defense, and a critical question at this juncture for pondering will be, how would the defense of a country be if it was run in 47 different ways? Now, let's get to work. On the panel introduced, we have tripartite representation, government leadership. Madam Mary Muthoni is well versed with the happenings at Afia House, Permanent Secretary, Public Health, Principal Secretary, Public Health and Professional Standards. Then Dr. Daniel Mwai, Presidential Advisor on Healthcare, as part of the government team. Then you have regulatory and implementation bodies. Dr. Abdi, Mohammed is not new to us as ADC. He was the chairperson of Social Health Authority. And Mr. Anthony Lenayara, who is the CEO of Digital Health Agency. And if you look at the current budget, he's the man who's smiling the most in this forum today. Then you have the NGO and unions, represented by Mr. Boniface Mundia, who is the health finance specialist from AMREF, and Dr. Dennis Miskellah, who is the Deputy Secretary General for KMPDU, to help us meet our objectives today. I'll go straight to the questions. And I will start with SHA, the pink elephant in the room. Dr. Abdi, the healthcare workers facing you today here are supposed to offer services that they cannot afford. Stories are told of doctors who are locked out of the system every 9th of the month because of a systemic culture or of I think your systems not being able to accommodate requests after every 9th for non-paying, which is not a fault of their own. How proud are you of this?
Thank you very much. I'm back.
Welcome back.
At least today you will listen to me. Because I would have forewarned you on that day on what to expect. But nonetheless, I'm happy to be back, and nothing personal. This work is public work. I'm here today. Tomorrow I'll be seated on this other side. No position is permanent. So So on the issue of SHA receiving money from employers and individuals, as a financier, if I don't receive money, I will not be able to pay providers. And when I am not able to pay providers, what happens is the providers will be on my case saying that they can't provide services. So yes, there has been a challenge, especially from government institutions delaying in remitting their statutory deduction. We have had that discussion and we are trying to find a solution on allowing some sort of leeway for public institutions so that as an employee of government, you are not disadvantaged from getting services. But we just need to align that when SHA says no, it's not SHA that's saying no. It's just the rules. We are applying the rules as expected. And it says by 9th of every month, I must receive statutory. Then by 14th, as the CS has said, I must pay providers. So you can imagine not receiving, I will default on the 14th. And that's where the issue is. But internally, I would say as a government, we are finding mechanism of allowing some leeway or doing at source deduction.
It is not SHA, you say, Dr. Abdi, it is the rules. Someone will argue that locking out government employees for government not paying is akin to just transferring money from the left pocket to the right pocket. And since the rules, quote unquote, are to believe is because of the digital system.
I think we're still going to be out in the hood because there's no way you can offer services, you can't. Secondly, we beg the governors and Your Excellency, Health Service Commission is what will save you the headache of having to address us on the streets every day. Let the commission handle that bit of it, be responsible, buy drugs and sort it. Let us have a way that we can have. If I, like for an example, as I finish, I graduated ahead of Davji in university. He is in your group P, I'm in N, simply because you made a mistake of working in different counties. Same patients, same country, same taxes.
Are they some which is healthcare workers are unreasonable? Thank you.
Thank you, Dr. Miskellah. You seem to paint a very grim picture of devolution. So the question is to, fortunately we have the horses.
The Principal Secretary for, I'll choose a part, standardization, professional standards, okay? So what national stewardship mechanisms can strengthen standardization while respecting devolution? As you address the policy measures that will make Davji not be in job group P, though he graduated later than Miskellah was in job group N.
Thank you. Thank you so much, Chair, for that question, but I must confess you have ambushed me. We agreed on a different question, he has changed. Nevertheless, tumezoea hii street. Mimi na yeye na Davji. Waziri, these people, I almost gave them an office inside my office, and especially last year. Now, that question is straightforward. When we look at devolution, and equally we are looking at the national government roles according to the Constitution of Kenya. And one of the things that we must be very clear about is the norms and standards in terms of the healthcare workforce in each level of any facility. When we talk about adequate staffing, we are talking about the primary healthcare level, who is supposed to be there, and do we have enough? Again, the secondary and the tertiary levels. Then the appropriate training. We must be able and be keen that anybody who is working in our facilities is adequately trained across board, whether you're working in a facility that is run by the national government or the county government. And then again, the staffing ratio. And you know this will vary depending with the facility capability. It will also vary in terms of the national guidelines that we have given, and equally the disease burden that we have across in that particular area. Then the second thing that I think must work is the standardization in terms of healthcare training. We have been having a bit of a glitch and you know, rubbing feathers even with the Ministry of Education, and this is something which is known, and I'm sure Waziri has already picked it up so that we can streamline in terms of standardizing the training of the healthcare workforce. We do not want, whether you are public or you're private, that you have your own curricula that you have created, that you're training your own doctors and nurses in a different manner than any other institution. So uniform curricula and the competency framework must be adhered to so that we achieve that which we want to as a country. Again, accreditation and certification, it must be uniform and across board so that we deliver issues to do with training methodologies, regulation, oversight. It must be standardized to a level that everybody feels comfortable and confident when they are working. And finally, we must create uniformed, skilled, and competent workforce. When we talk about the scope of practice, I know this has been a thorn in the flesh too, because of different cadres emerging and others feeling probably they have not been looked into properly. We are already reviewing the scopes of practice for every other cadre as we move forward, because we need to know what are your roles and responsibilities that are in line
with your training and practice, so that we also remove the confusion that is there in the market. Therefore, this is a conversation, and the Ministry of Health does not work in isolation. You and me must come together. We must discuss these issues, just like the way we discuss issues when there is a strike. And I'm sure this, if we are not in line, and this Abdi should listen to, together with Miskellah, if you don't make it better this year. And the government of William Samoei Ruto is a listening government. That is why, I want to repeat, and that is why you have the Waziri himself here. He would have decided to send somebody. He would have delegated to myself, to Oluga, or anybody else. But he has come in person, because this conversation is a collective responsibility, that every other time we have an issue, we have to bring ideas on the table and see which is the best way forward for all of us. Thank you. I hope no more questions.
Thank you, Katibu. And as I acknowledge the CEO of Kenya Medical Practitioners and Dentists Council working in, this question is still on standards, and it addresses a critical issue of apartheid in medicine. Poor medicine for poor people. I'm sure most of the people are middle class who want their children to be seen by a pediatrician, their wives and sisters to be seen by an obstetrician. But we are creating standards whereby that will provide poor medicine for the poor people through other task-shifting methods that will not be accepted in the global north. A case in point is the recent accreditation to do and perform clinical procedures by the the community oral health officers that pass through the standards committee. I hope.
Okay. Thank you. Really, this is work in progress. because we are already working on quite a number of issues, including in terms of medicine. And if you look at the digitalization that we are creating even at the Ministry of Health, it is to make sure that some of these loopholes are curtailed even from the manufacturer at the manufacturing point, so that we are able to also allow the kind of drugs that we really need in our country. The track and trace system that is being developed at the Ministry of Health will help us remove the blockages that we have had before. And you will see this happening, you will see a change as we move forward. We allow ideas to come on board equally, and also questions. Should you see like we are loosening up in terms of areas that we are supposed to be firm in regards to the products that are coming into the country?
Thank you. But more specifically, could you address the aspect of task shifting? Would you want your legacy to be that of era where task shifting from proper medicine to the close gap measures that you used to do in the 90s and years gone by be your legacy? More specifically, we want to know what is the scope of practice for other cadres that are more recently being elevated, and does it pass through the professional standards?
Let's allow Dr. Abdi to answer that.
I understand the one for co-host came from India, because that is usually his pet beef. But more importantly, for the first time, at least we have a CS who has put that as his agenda number one. And the DG has been tasked to do the scope of practice for all cadres. And very soon we will have that published, gazetted, so that it's clear on what is the scope of each of us. But I know internally we will also have our own fight, because I used to be in KMPDU, where you find plastic surgeons saying they can do this, then you have maxillofacial saying they are the ones who are supposed to do. So it will also come within us. We will have that fight on what is the scope of each of the subspecialty and specialty amongst us. But that's one thing that I hope will be the legacy of the CS, because the DG has been tasked to do the scope of practice all cadres.
Thank you. Thank you. Dr. Mwai, you advised the President. We have just 8,000 doctors as per the KMPDC website registered to practice in a country that has a severe shortage, and we are still having unemployed doctors out there on a policy that started because of a strike that was led by a Secretary General called Dr. Mohammed in 2017. After that, direct employment was stopped, which was like a punishment policy. First of all, do you advise the President? Yes, I do. And does he listen? He listens very well. To start it off, what advice have you given him about the interns pay, which Dr. Miskellah has insisted us to be as per the CBRS? What advice have you given him about the interns pay, which seems to be to light embers of fire every other year?
Yeah, so thank you very much. I want to begin by highlighting that the President listens. And the other thing I want to highlight is that we sat down and crafted this health agenda, not as a political tool, but rather as an agenda that needs to be delivered for the benefit of having good healthcare services for Kenyans. That's the reason we drafted the manifesto. That's the reason we drafted the whole architecture of what we should land with. I am usually very happy when I see you make noise, actually, so to speak, on this. Because I do believe that a good agenda is actually not visual with an open eye, just like that. If it was obvious, we would just do a populistic intervention, make you extremely happy for 2 years, then we go back to zero, as we have done since the Deal Bill of 2003. So I want to reiterate the fact that every government has visited Thailand 7 times. This country has gone to benchmark there. 0 times have we implemented. 0. So what we are trying to do is to walk a straight, narrow, sometimes painful, but it is what it takes to be realistic and adjust the problems. Now, having said that, I want to highlight I'm a strong believer that there should be a strong mechanism to solve the human resource challenges that we have in the health sector. Very strong. And that's against the backdrop when that established the panel that your chairman was a member. So one question you should ask the chairman, the deputy SG, sorry, was a member, so that we try and get real solutions, not just supervision, patching, ile kilaka, unapiga kilaka, inatoboka juu ya kilaka, unapiga ingine. Now, if we were to solve that problem, we have to get into bedrooms, we have to discuss real solutions and how that should be done. Now, having said that, I do think that there are 2 things that I want to highlight. One is that this health agenda centers around output-based financing, where if you are providing service, the service should be paid for and you should receive the resources. Now that comes to the FIF, which you know that the money is coming to the hospital or to the facility that is providing service, which should interest your members, who should be paid more, because they are the ones providing that service, right? But the architecture through which that should be implemented should come from you people. You'll be thinking also, how is it optimized? We are not in this alone. We are this together with you guys. Having said that, the other important thing is that the scope of service provision, promotion of staff, training of staff, the welfare of staff cannot be ignored if we have to achieve this agenda. And that is very clear. It is communicated to the President, and the CS is here. He will talk about those things because he has a larger call for the same. Now, to the question you have asked, the issue of internship has been with us since Kibaki time. So that means the way we solve it must be wrong. Because if it has persisted across these governments, and you either go to the streets, you are given small resources, you come back. I'm not saying you should have stayed for long. In Mwai's time, you went, I think, for 100 days, right? So it is important for us to get a real solution. Now, and the real solution does not surround 206,000, 106,000, 70,000. That's not where the solution lies. The solution lies in treating the problem. Now, government must be able to predict and plan for interns. Simple rule. That means the numbers that are coming in for training must be agreed upon and predictable for them to get to government budgets. Now, if we want to just say, oh, money will be allocated, that's not how government works. And Kenya is known for having rules. And those rules you are saying were made by humans, were actually made to govern, including the healthcare sector. So my belief is this. One, we need a candid discussion on the intern program because it's perennial, keep on occurring. Two, we need to agree on the number that need to be trained. All right? That number, we project the budget for it to be there by the time the interns are coming out. But sometimes government does not know who is coming.
You train in Australia, you come here, you want internship. You train in Uganda, you come, you want internship. Now, how does government plan for that, surely? All right? So we need to streamline the number of training, make them projectable, and then Waziri does his job, fight for the resources to make sure that each year he knows how much is needed. But now he has a problem. Number two is that we have, and this is now where opinion comes into. Students are either government supported or some private supported. We either have a law to make sure that we have a control of the private students because they are not known. I can decide today I will take my child to a private facility. They are trained, they become a doctor, and I was paying 1 million in that training facility. It was not a problem until the internship comes. So we have to make a decision. Does the mechanism that pay you fees transit you to up to when you get the license? Or does it take you to where you finish education and then the government take you for internship? So we need a better discussion. Logical, let's be factual. We want to get solutions. And that is why the committee had been created to give us those solutions. Even without, we should still aspire to do that. Lastly, we should employ doctors. We have to employ doctors. And Abdi will tell you, because I many times call him, many times to call him anyway, that we cannot work as a union of the 1950s, where the only thing was there is populism and agendas that ideally are supposed to deliver on the streets. We must become a professional union, internalize issues, analyze them and say, this is where our members will benefit. And when we were working on the civil servant scheme, you should have said you are there with your brother, right? And we brought you there. Why did we bring you there? Because the desire of this government, most of our health sector, is to solve the problem. Now, if you have a solution, that is where we say, bring it. And you did a very good job. I didn't even know this man can think very well, by the way. Right? So, when we sat there, he was saying, this is what we need for our members, okay? The benefit cannot go below what they have been, right? The benefit, one of the, when he was highlighting, and if I lie, please tell me, because I really do, I hate politics, I'm not a politician, I'm a technical guy, but I'll tell you the reality. So what he said was, the benefits of the past, at least we cannot go below when we come to SHA, right? And that was the consideration. And you look at the benefits as configured now are nothing less than what was in the other fund. The issue that of course is at hand, and it's good to be realistic and truthful, is that issue of dropping every on 9th. And that must be solved. And I'm sure the CS is also nodding because he has been telling us we must solve it. Now, after that, we must look at this money we are paying into facilities. We are paying capitation money. We are paying chief resources. The providers of those services happen to be medical doctors and other healthcare workers. We must think all the money we pay, approximately 15% to 20% is consultation fee, which happens whether it's primary or chief, which is money that goes to human resource. How do we harness this human resources so that we pay for the doctors you are talking about? Because then the money is there. Because that money is going there because they are providing. So where you need to tweak your thinking is also help us. We craft a way that the doctors, the healthcare workers are also paid on the money that is going to the facility. That way, the 80,000 doctors will be employed. They should not have a problem. Alright? Because I am sure your doctors are hard working. If they are not the ones working, those ones cannot be paid. But the ones that are working, we are giving a service and we are sending the money for it. So there is no reason
they should not be compensated well. So we have to think re-engineer so that we get these monies to the real people. And that is why this reform is happening. Thank you very much.
Thank you. Very briefly, because we need to move on. Dr. Mwai is an accomplished economist, and I tend to believe, personally to believe he was the brainchild behind the policy direction shift in sharp, but I digress. When you look at the budget estimates for this year, which were passed, a lot of money has been again allocated for infrastructure projects, about 85 billion. I pick specific scheme. We are again purchasing MRI machines, dialysis machines, and you know the conundrum.
Yes, I know.
However, the budget seems to have only purported to allocate money to employ 1,200 doctors, which you want to believe are interns. What are these machines going to do?
Thank you. I want to first tell you that the difference between the previous mess and the one being rolled out is like heaven and earth. So it's good we tell each other the right thing. Heaven and earth, that's the difference between the new equipment program and the past. Because the past was a lease program where you went and placed a machine in a hospital, whether it works or it doesn't work, I don't care. Alright? And we know that the contract expired and ended without some of the equipment actually being removed from the cartons that took them to the facilities. Right? These are realities, you live there. Now, in the new system, the government is saying, you place the equipment in the facility. Okay? Let the equipment provide the service. I will pay for the service. So if the equipment have no human resource, it will not provide service, nobody will pay for it. If it has no room to actually put it, it will stay in the hospital, nobody will use it, nobody will pay for it. So that's a major difference to begin with. Therefore, even for the equipment, you are paying for the output of the equipment, not the equipment. The same parameter, we are saying the same parameter is utilizable or is very effective in financing for human resource. You are providing a service, I am paying for it. So the same way the equipment is being paid for providing that service, it's the same way the facility is receiving resources for the service it has provided. Now that becomes an extremely sustainable healthcare financing model. Because as long as a Kenyan is receiving service, there is money to refinance that inputs that have been used to actually provide that service.
Thank you. We'll pick it up from there in the second panel. In the interest of time, I'll just request Madam PS to give the closing remarks for the panel. And thank you all.
The one thing that we cannot avoid when we are rolling out the universal health coverage is human resources for health. We may have the infrastructure, we may have all the equipment, we may have even the commodities, but we must invest in human resources for health, and more so the specialized human resources for health like the doctors. Thank you.